Bismillah Rahman Rahim. Quote of the day, and be patient, for indeed Allah does not allow to be the lose the reward of those who do good. So today the topic of presentation is natural history of disease, ways of expressing progress, prognosis. I am Dr. Iqbal, PGR Community Medicine, and presenting under the supervision of Professor Dr. Saya Afzal. So learning objectives are natural history of disease, case fatality, 5 year survival, observed survival, median survival time, relative survival time, two approaches for calculating observed survival over time, the life table approach and Kaplan-Meier method, recent updates and MCQs at the end. Learning outcomes. By the end of this presentation, participants will be able to compare five different ways of describing the natural history of disease, case fatality, 5 year survival, observed survival, median survival, and relative survival. To describe two approaches for calculating the observed survival over time, table approach over and the Kaplan-Meier method. So, natural history of disease. The natural history of disease refer to the progression of a disease process in an individual over time in the absence of treatment. So it has two phases, a preclinical phase and the clinical phase. Preclinical phase include biological onset of the disease, pathological evidence of the disease, and appearance of sign and symptoms. The clinical phase include the appearance of sign and symptoms, seek medical care, and then diagnosis and treatment. So the outcome of disease will be cure, control, disability, or death. Next is the progression of ways of expressing prognosis. There are five ways: case fatality rate, 5 year survival rate, observed survival, median survival rate, and relative survival rate. So the first one is the case fatality rate. Case fatality rate is the proportion of an individual diagnosed with a particular disease who die from that disease within a specific time period. It is measured of disease severity and is common used during the outbreak or epidemic. Key features of case fatality rate are measure severity of the disease, expressed in percentage, and useful during epidemic and outbreak. Formula of case fatality rate is the number of deaths due to the disease divided by the number of diagnosed cases of the disease multiplied by 100. Second is the 5 year survival rate. The 5 year survival rate is the percentage of people who are alive 5 years after the diagnosis of the disease. The term frequently used in clinical medicine, particularly in the treatment of cancer and chronic disease. So the formula of 5 year survival is number of patients alive after 5 years divided by number of patients diagnosed multiplied by 100. Despite the widespread use of 5 year survival interval, it should be pointed out that there is nothing magical about 5 years. Certainly, no significant biological changes occur abruptly after the 5 year in the natural history of disease that would justify it as an end point. However, most deaths occur from cancer typically occur during this period after the diagnosis. So, the 5 year survival has been used as an index of success in cancer treatment. The problem with the use of 5 year survival has become a more prominent recent year with the advent of better screening programs. For example, a woman who had a biological onset of breast cancer in 2005, because the disease was subclinical at that time, she had no symptom. In 2013, she felt lump in her breast, which precipitated as in a visit to her physician who made diagnosis. The patient then underwent a mastectomy. In 2015, she was died of metastatic cancer as the measure by the 5 year survival, which is often used in oncology as a measure of whether therapy has been successful. So this is not a success because the patient survived for only 2 years after the diagnosis. So the 2000 in 2005 there is the onset of the disease, and in 2013 she was diagnosed and treated. After 2 years she was died. So this was not a success. Now let's imagine that the woman lived in a community where there is an aggressive breast cancer mammography screening campaign. As before, biological onset of the disease occurred in 2005, but in 2010 she was identified through the screening as a very small mass in her breast. She had surgery in 2010 but died in 2015. Because he was survived for 5 years after the diagnosis and therapy, she would now be identified as a therapeutic success in term of 5 year survival. Death still occurred in 2005. In 15, the patient life was not lengthened by the early detection and the therapy, but the interval between the diagnosis and her death was increased through the early diagnosis. The interval between the early diagnosis and in 2010 and the made possible by the screening test and the later usual time of the diagnosis is 2013 is called lead time. So lead time is the time interval between the early detection of the disease and the point at which the disease diagnosis has been made on the clinical symptom. The benefit of the program has been seen in terms of its outcome. So A is the outcome of the disease and B is the outcome of the disease which is expected when the disease is detected at the earliest possible moment. So B and A is the benefit of the program. Second is another problem with the 5 year survival is that if we want to look at the survival experience of a group of patients who were diagnosed less than 5 years ago, we clearly cannot use this criteria because 5 years of the observation are necessary in those patients to calculate 5 year survival. Therefore, if we want to assess a therapy that was introduced less than 5 years ago, 5 year survival is not an appropriate measurement. The uses of 5 year survival are 5 year survival can be used to compare the effectiveness of treatments. It is more useful in aggressive disease that have shorter life expectancy, such as lung cancer, and less useful in case with a low life expectancy, for example, prostate cancer. Improvement in the rate are sometimes attributed to improvement in the diagnosis rather to improvement in the prognosis. To compare the treatment independently from the diagnosis, it is better to consider survival from the reaching a certain stage in disease or is treatment. So third one is the observed survival, which is defined as observed survival is an actual proportion of the patient still alive after a specific period followed diagnosis or treatment, regardless of the cause of disease. So the rationale for the life table, another approach to quantify prognosis is to use actual observed survival of the patient followed over time, based on knowing the interval within which the event has occurred. For this purpose, we use life table. So, a hypothetical study of the treatment result in the patient treated 2010 to 2014 and followed in 2015. So, these are the years in years of treatment. So, these are the patients that are enrolled in the respective years, and these are the number of the patients that are treated and alive after every year. So, if we rearrange this data, this is a year in which these patient number of patients who were treated and after the first year 44 patients were alive, after the second year 21 patients were alive, after the third year 18 patients were alive, and so on. In the same way, 2011 number of total patients that were enrolled 62. After first year of the treatment, 31 patients were alive, and after second year, 14 patients alive, and after third year, 10 patients were alive, and so on. So, how to use a life table? And what is the probability of surviving for 1 year after the beginning of treatment? To answer this, we divide the total number of the patients who were alive after the first year after the initiation of treatment by the total number of the patients who were started treatment. So for getting the probability of surviving the first year, we divide the total number of the patients who were alive after the first year, that is 197, divided by the total number of the patients that are enrolled in this year, that is 375. So we get the probability of surviving the first year, that is 0.525. Next is what is the probability that have been survived the first year after beginning of the treatment. The patient will survive the second year. So to get the probability of surviving the second year, we divide the total number of the patients that are survived after the second year, that is 71, divided by 197, the total number of the patients that were alive after the first year, minus 43 patients that were enrolled in last year, in 2014, whom we have no further data of observation or treatment. So we get the probability of surviving the second year is 0.461. Next is, given that a person has survived in the end of the second year, what is the probability on average that she or he survived the end of third year? So to get this, probability surviving the third year, we divide 36 that are the patient alive after the third year divided by 71. The patient were alive after the second year minus 16 patient. 16 of them because we are that are enrolled in the late year, and we do not have any further information regarding these 16 patients. And probability of surviving each year of the study. So the probability of surviving the first year, 197 divided by 375, so 0.525. Probability of surviving second year, given survival in the first year, so we divide the total patient that were alive after the first year divided by the total second year, that divided by the total number of the patient that were alive after the first year, and minus 43 patient that were enrolled later year. So in the same way, probability of surviving third year, fourth year, and fifth year. Next is the cumulative probabilities of surviving different length of time. Probability of surviving first year, P1, is equal to 0.525. In percentage, it is 52.5. Probability of surviving second year, we multiply by P1 multiply by 2. So we get the probability of surviving second year, which is 0.525 multiplied by 0.461. So we get the 0.242, which in percentage 24.5, and in the same way. Next is calculating the life table. Let's now view the data from this example in a standard tabular form in which they are usually presented for calculating a life table. The columns are follows. The first column is the interval since the beginning of the treatment. The second column is the number of the subject who were alive at the beginning of each interval. The third column, the number of the subject who died during that interval, and the fourth one show the number of number who withdrew during the interval. That is the number of the study subject who could not follow for the full study period, either because they are lost to follow up or because they were enrolled after the study has started. So to get the effective number of exposed to risk of dying during the interval, we subtract column 4 from column 2. The proportion who died during the interval, we subtract column 3 by column 5. To get proportion who did not die during the interval, we subtract the column 6 from 1. To get the cumulative proportion who survived from the enrollment to the end of the interval, which is known as the cumulative survival. Next is the Kaplan-Meier method. The Kaplan-Meier method is also a survival analysis method that uses exact the time then when event occurred. In Kaplan-Meier method, predetermined intervals such as 1 month or 1 year are not used. Rather, we identify the exact point in time when each death or event of interest occurred, so that each death or event terminate the previous interval or a new interval. The number of the person who died at the point is used as a numerator, and the number alive up to that point, including those who died at that point, is used as a denominator. After any withdrawals that occurred before that point are subtracted. So this is an example of sample hypothetical study in which 6 patients were studied, of whom 4 died and 2 rose the follow-up withdrawal. So the death occurred at the 4, 10, and 4, 10, 14, and 24 months after the enrollment of the study. Column number 1, the time of the each death from the time of the enrollment. Column number 2 show the number of the patients who were alive and followed at the time of death, including those who died at that time. Column number 3, the number who died at that time. Column number 4 shows the proportion of those who were alive and followed, who divided by the time who died, divided by the patient who died at that time. So we divide column number 3 column number 2. So column number 5 is the proportion of those who were alive and survived. So we subtract the column number 4 from 1. 6 1 is the cumulative survival, the proportion of those who are initially enrolled and survived to that point. Note that the data are plotted in stepwise fashion rather than in a smooth slope, because after the drop in a survival result resulting from each death, survival then remain unchanged until the next death occur. Next is the application of Kaplan-Meier method. When information on the exact time of the death is available, the Kaplan-Meier method clearly makes fullest use of this information, because the method are used to define the intervals. Although the method is well suited to the study with a small number of patients, today the computer programs are readily available that make this method applicable to the large data as well. Many of the study is published literature now report data on survival using a Kaplan-Meier method. So next is the comparison between the Kaplan-Meier method and the life table. Uh, Life table allow the censored data and cumulative probability calculation. In Kaplan-Meier also allow the censored data and cumulative probability calculation. Uh, Life table is a time dependent, whereas Kaplan-Meier is the event dependent. Unreliable in a small data set life table, whereas Kaplan-Meier is reliable in the small data sets. Live table show the uniformity assumption, whereas Kaplan-Meier no assumption is made about the timing of the sensing. Next is the median survival. Median survival time is the time in which 50% of the patient in the study group have died and 50% are still alive after the diagnosis of the treatment. Median survival offers two advantages over the mean survival. First, it is less affected by the extremes, whereas the mean survival can be significantly affected by a single outliner. Second is, if we use mean survival, we would have to observe all of the death in the study population before the mean could be calculated. However, to calculate median survival, we would only have to observe the death of the half of the group under the observation. Next is the mean survival time versus the median survival time. Mean survival time is the time is estimated as the area under the survival curve in the interval to T0 to Tmax, whereas the median survival is the length of the time, that is 50% of the study population survive, or median survival is the point of time when T is 0.05. Next is the relative survival. Relative survival is the ratio of the observed survival in a group of the patient to expected survival in a similar group from a general population without the disease. It helps estimate how much the disease itself reduces the survival by removing the effect of other causes of the death, like age or accident. So the relative survival formula is observed survival in a people with the disease divided by the expected survival if the disease were absent. Next is the does relative survival really make any difference? When we look at the older age group, which have the high rate of mortality from other causes, there is a large difference between observed and the relative survival. However, in the young person who generally do not have died of any other cause, observed and the relative survival for cancer of the colon and the rectum do not make differed significantly. So next is the recent updates. Assessment of a median and the mean survival time in a clinical cancer clinical trial. So the introduction is a clinical trial often reported as an estimated median survival time to facilitate interpretation. However, the median make limited use of the survival curve, focusing on the center of the exclusion of the other information. Concern exists about the median stability as measured by the width of its cells. In clinical trial with a few events are the follow-up, the median survival may not be reached. In contrast, the restricted mean survival time provide clinically interpretable and global summary of survival and may be more stable than the median. Instability can be obscure the clinical interpretation of the survival estimate. Wide CL suggests that the true estimate fall within the broad range of the possible value, creating uncertainty and limiting the usefulness of the such survival estimate for clinical decision making. To determine the relative stability of the estimate mean and median survival time, who conduct a so this conducted a cohort study, analyzed the reconstructed individual patient level data from plan measure curve for a comparison collection of 203 phase 3 cancer clinical trial. Next is the reconstruct individual patient data from the published plan measure survival curves. The background of this study is when applying the secondary analysis on the published survival data, it is critical to obtain each patient's raw data because the individual patient data approach has been considered as the gold standard of data analysis. So the conclusion of this study was that individual patient data from the plan measure has great flexibility and accuracy to reconstruct IPD from the published the plan measure curve with the different shapes. We believe that our packages and the Shiny application will greatly facilitate the potential use of quality IPD and advanced use of secondary data to facilitate informed decision making in medical research. So next we come to the MCQs. MCQ number one, what does the natural history disease refer to? A, genetic origin of the disease. B, treatment outcome of the disease. C, the disease progression with the effective treatment. D, the impact of lifestyle on disease prevention. E, the progression of disease over time without treatment. So E is the right option. What is the key feature of case fertility rate? A, it expressed in the year. B, it measures the effectiveness of treatment. C, it commonly used in chronic diseases. Disease. D, it measures the severity of disease and expressed as a percentage. E, it only applies on non-communicable diseases. So D is the right option. MCQ number 3, during an outbreak of a novel viral infection in a community of 10,000 people, 800 individuals were diagnosed with the disease. Out of these, 120 died within the 3 weeks of diagnosis. Public health officials are now assessing the severity of disease to guide response strategy based on information provided. Which conclusion is the most accurate regarding the case fatality rate and its application? A, the case fatality rate is 12%, suggesting the infection has a low transmission rate. B, the case fatality rate is 15, indicating the mild disease that occur no urgent public health response. C, the case fatality is 10%, implying the infection is less deadly than other epidemic. D, case fatality is 15%, highlighting the need of rapid and medical and containment interventions. E is the 1.2, suggesting only a small proportion of the population is at risk. So D is the right option. This is an explanation of the MCQ number third. MCQ number 4 is the in survival analysis censoring occur when a patient dies from the disease of interest. B, a patient complete 5 years of follow-up. C, a patient exact survival time is unknown due to loss of follow-up or study. D, the plan measure curve reaches zero. E, a patient received treatment during the observation period. So C is the right option. Which scenario best demonstrates the limitation of use of 5-year survival rate in evaluating cancer treatment? A, it includes the patient loss to follow-up. B, it overestimate benefit of diagnosis is made it early, but survival time is not approved. C, it excludes patients with comorbidities. D, it underestimates the survival in the pediatric cases. E, it applies to the hospital-based cases. So B is the right option. MCQ number 6, and researcher analysts want to evaluate cancer survival in two groups using life table. Group A starts with 300 patients. 180 survived the first year, which is the probability of surviving the first year. A 0.45, B 0.50, C 0.60, D 0.70, E 0.90. So D is the right option. MCQ number 7, a national screening program detect cancer 3 years earlier than the usual clinical diagnosis. However, the survival time after the diagnosis increased with the actual lifespan remain unchanged. What should be the public health team should conclude about the program effectiveness? A, the program increase overall survival time. B, the program reduce the case fatality rate significantly. C, the program introduce lead time bias without improving the outcome. D, the program cured cancer at the early stage. E, the program failed due to the 5-year survival rate. So
C.
C is the right option. MCQ number 8, which of the following has a good index of severity of short-term acute diseases? A. Caste-specific disease. B. 5 year survival. C. Case fatality. D. Standardized mortality ratio. E. Median survival time. So C is the
C.
right option. Case fatality rate. MCQ number 9. In which of the following situation is a live table approach more appropriate than the plan Mayer method? A. When exact timing of event is known. B. When survival probabilities need to be updated with the every event. C. When data are grouped into large fixed time interval. D. When calculating the hazard ratio. E. When comparing the multiple treatment group with a small size.
C.
Yes, C is the right option. MCQ number 10. A cohort of 500 breast cancer patient has a 5 year survival rate 80%, and the expected 5 year survival in the general population is 90. What is the relative survival rate and what does it imply? A 70% the disease significantly reduce the life expectancy. B 88.8 only the minor impact of the disease on survival. C 90% survival is equal to the general population. D 88.8 after the adjusting other causes disease impact is moderate. E 55% high disease specific mortality. So D is the right option. Relative survival is equal to the observed survival that is 80% and expected survival that is 90. So multiply by 100. So the answer is 88.8. This is the answer key. This is the YouTube channel where the recording of this presentation will be uploaded. And thank you everyone.